Before I get talking about antimicrobial therapy, I want to talk about a couple of differences in bacteria that we deal with. Um, if you take a look here, I have drawn a couple of bacteria out. There's supposed to be a little flagella that are hanging out the back. And just mainly to show you what a gram-negative and a gram-positive bacterium looks like. You have a cell membrane. You got all, you got the little stuff inside here, all organelles. Right around here, you have the peptinoglycan layer, um, or peptinoglycin layer. And anyway, and then around the outside of it, you have another cell membrane. That is the gram-negative bacteria. And they call it gram-negative because it does not take up stain well. So because of this outer membrane. Now this guy over here is a gram-positive. It's the same thing. It's got the cell membrane. You got all your organelles in here. Then you got that peptinoglycan layer out here, right? But there is no outer membrane. So it takes stain. Stain comes and it sticks to this stuff real good, right? And then, so then you can see it, right? It stains. So they call that gram-positive because it does take up stain. So the lack of the outer layer makes it so that the gram-positive bacteria will take up the stain, and that's why they call it gram-positive. Um, so knowing if a bacteria is gram-positive or gram-negative gives us an idea of what antibiotic will work against it. Now the way to say that is what antibiotic is a particular bacteria is sensitive to. For example, if a bacteria is sensitive to penicillin, that means penicillin will kill that particular bacteria. Another thing to know is that bacteria can be aerobic or anaerobic. An aerobic bacteria requires oxygen to survive, and an anaerobic bacteria does not need oxygen to survive. Now, from my opinion, as I look around, as I look at what kills what and everything, I'd say anaerobes, they can be a bitch to kill. So it's handy to know which antibiotics will kill the anaerobes. Antibiotics are one of the most allergenic medicines we use, something that you got to be aware of. 8% of the population are allergic to penicillins. 4 to 5% are allergic to cephalosporins. And there's some crossover there because they're both beta-lactams. Any patient on antibiotic therapy needs to be closely monitored for allergies. Right? So that's something that you need to be aware of, is that any patient on antibiotic therapy needs to be closely monitored for allergies, especially patients that have shown hyperimmune responses in the past. This would include patients with history of allergic rhinitis, right? You might say, well, they have hay fever or whatever, but they got allergic rhinitis, right? They get them really bad runny nose and itchy eyes and all that stuff, and they get it a lot. So those people there have kind of a hyperimmune response. Asthma, patients with asthma, you have to monitor them closely because they're at risk for having an allergic reaction to the antibiotic. Now, antibiotics often cause nausea, vomiting, and diarrhea, right? The GI upset is a real common thing because you're killing off some of those bacteria, right? Some of your normal flora bacteria in your gut. And by doing that, the other things that aren't sensitive to the antibiotic will overgrow. And any overgrowth of your normal flora is an infection, right? It might be normal flora and on most circumstances becomes a pathogen. So GI upset, I think all antibiotics can cause GI upset, some much worse than others. Broad spectrum antibiotics can cause GI upset more than narrow spectrum. And by the way, broad spectrum means that it's an antibiotic that will kill a lot of different germs, right? A lot of different pathogens. And a narrow spectrum means that it's a little narrower, you kind of kill exactly what you want. So you don't want to use those broad spectrums for too long of a time, or you don't want to use them if you don't have to, because you don't want to be killing off normal flora because it really sets you up for a secondary infection. And a secondary infection would be like an E. coli infection of the gut, right? Because you've killed off all the normal flora and now it's overgrown with the E. coli, or thrush in your mouth, right? There's several thrush in any place where there's yeast growing, and you really set yourself up for that by taking broad spectrum antibiotics for a long period of time. Another thing is antibiotics can be pretty hard on the kidneys, right? So they can be nephrotoxic, kind of a common thing. Another thing that you see is ototoxicity with antibiotics, especially like gentamicin. They're kind of known for that. And so they can damage the nerve for hearing. So that's something that you got to be careful of. As far as the next nephrotoxic, you got to monitor their kidneys, right? You got to watch their BUN and creatinine, see if they're staying in normal range, because that could be a sign that you are damaging their kidneys. Because the nephrons of the kidneys, they're very sensitive to these different drugs that get shoved through them, right? And the kidneys are what pumps your antibiotics out. It's how we excrete them. So we're overworking your kidneys a lot. And a patient who's on loop diuretics, if they're already on loop diuretics like furosemide, hydrochlorothiazide, these things are already taxing the kidneys and forcing them to work a little harder than they normally would. Antibiotics on top of that, you really need to watch for nephrotoxicity. And you got to remember, subsequent use of an antibiotic leads you to a risk for a severe reaction, right? If they've had a small reaction once before, you don't ever give it to them again, because the second time around will usually be a severe reaction. And very often they may have had no reaction. So if they've only had this antibiotic once, this subsequent use, definitely watch them for allergic reactions, right? Because you say, oh, they had it once. They're not at risk. Oh no, they're at higher risk the second time, because you have been exposed to it once and now your body's set up an immune response toward it. And that's actually when you get the first or the reaction. It's not the first exposure, it's a subsequent exposure. Okay, so now I'm going to talk about penicillins. In fact, I'm going to talk about beta-lactams, which also include cephalosporins, which are not a penicillin. But normally when we talk about beta-lactams, we are talking about penicillins and cephalosporins. And it's kind of handy, a little bit for me anyway, to know the molecular layout of these things, how they look on there. Now I've drawn it out here. You got like a carbon. I think you got like a hydrocarbon out here, and they got some other. But anyway, this is kind of the layout of it. I don't, the carbons, the nitrogen, hydrogen, carbons, and that's not important. I really don't care about that at all. In fact, I don't think I got them all right, but it's close. But anyway, what I'm trying to point out is take away all these letters. It kind of looks like a house with an attached garage and maybe the little canopy out on the side there, so you can park in the garage or you can park over next to it, right under the canopy. Well, I kind of remember that as the layout of the beta-lactams, penicillin specifically, beta-lactams. This picture in my mind kind of helps me when I start thinking about the different forms of resistance that some of the antibiotics have towards this. Now, this is the molecular layout of the penicillin. Well, it was when it had all of the other elements written in there. But beta-lactam antibiotics, of course, the first one we had was just the basic first penicillin that we had. And in order to tweak that, what they do is they take this here, this side chain is what I'll be calling it, right? The side chain, and it gets tweaked, right? Because right here you have some hydrogens, they end up coming off with some different stuff here, and then sometimes you'll actually see where they get a little thing like that drawn in the end, where they've added things to the molecular structure of the penicillin in order to give it different properties. Right, so they add stuff off to that little side chain there, gives them some of these different properties that they might want to have. So we have a whole lot of different medicines, a whole lot of different antibiotics, but they're all penicillins. They're all beta-lactams. They all have that same structure, that house and everything. It's just that side chain, that little canopy that I showed at the side there of the garage. Which, I mean, they're not garages and they're not canopies, but it's an easy way for me to remember it because I'm not a chemist. But anyway, that little part is the only thing they have to change. The rest of this stays the same, so it remains pretty much the same medicine. The important thing about that is if you're allergic to one of them, you're allergic to all of them, right? If you're allergic to one of those penicillins, you don't give any of those penicillins because you will have a reaction to them all. So, but they do this because a lot of things can be accomplished by making these small changes. For example, penicillin G, the first penicillin that they made, it could only be given parenterally, IM or IV, right? And IM, I believe, is how it was always given. It could not survive the acidic gastric environment of the stomach, right? So you couldn't take it PO. A couple changes to that little side chain, add some penicillin salts and stuff that they did, way beyond my brain, and they made it so now you can take it PO, right? Just a couple little changes that they made, and now they can take these penicillins by mouth. Another thing is sometimes it's not even an altering of the actual molecular thing itself, it's adding it with another medicine or some other product. One good example is probenecid, Probenecid, probenecid. It's a medication that's used for gout. The medicine, what it does is down in the kidneys, it makes it so that the kidneys will excrete more uric acid. And then by excreting more of the uric acid, you have less uric acid out there to form uric crystals, because uric crystals are really the pathology of gout. So the probenecid causes that, but it does some other things down there. It causes you to excrete more uric acid, but it causes you to hold on to. It slows down the excretion of penicillin. So if they happen to be on probenecid for gout and you give them an antibiotic, you got to be careful about them becoming toxic because they're not getting rid of it. Another thing about this probenecid, though, so it can be added to penicillin to enhance the therapeutic effect by allowing it to remain in the body for a longer period of time. They've made some changes to make some penicillins more broad spectrum. An example of a broad spectrum penicillin is ticarcillin, Ticarcillin, and that's good at killing aerobic and anaerobic bacteria. And you add clavulanic acid to it, and it will also kill Staph aureus, right? Which we'll be talking about more here in just a couple minutes. Before we start talking about bacteria that is resistant to penicillins, let's talk a little bit about how these penicillins work. So like I said, beta-lactam antibiotics, penicillins are beta-lactam antibiotics. And what beta-lactams do is they attack the cell wall. More specifically, they break the peptide bonds in the peptinoglycan layer of the cell wall. This attack creates a leaky wall. The inside of the bacteria is hyperosmotic. This means fluid will rush into the cell and cause that cell to burst. Now, at first, penicillin was effective at killing both gram-positive and gram-negative bacteria for about 10 years. Then Staphylococcus aureus, which is a gram-positive bacteria, developed a resistance. Over the years, more and more Staph aureus have become resistant. Today, they say that 90% of Staphylococcus aureus are resistant to the old penicillin. Now, when I say the old penicillin, I need to talk about what we have done, how we have tweaked that little canopy, right, that side chain on the penicillin molecule to make it so that it could kill these things that had been resistant to it. So we got to stop and think about how did they become resistant? Well, what they did was they released this enzyme called penicillinase or beta-lactamase. So they released this penicillinase, right? Ends in ase. That means it's an enzyme. What enzymes do, they break stuff up. You want to know what it's breaking up? What's this enzyme breaking up? You look to the front of the word, right? So you look to the front of the word, penicillinase. Well, ace means breaking something up. Front of the word of penicillin, it breaks up penicillin. So in other words, what it does is it comes in, and you know that how that it showed that how I showed you that house. right? I showed you this house here, right? Well, penicillinase was being released by the Staph aureus guy, right? This guy's out here. Boom, and it's releasing penicillinase, and these are like boulders. Boom, and it's throwing these boulders at the wall there, and it knocks this house down, crashes through that wall, knocks that house down. And you knock that house down, the beta lactam ring is broken, and the penicillin is now dead and unable to perform the function of killing bacteria. So in that way, Staphylococcus aureus has become resistant to penicillin. So what did we do? How did we fix this problem, right? This is a big problem because now you got a bacteria here that causes a lot of illness and a lot of infection, and we're unable to kill it with our penicillin because that's the only guy that we had back then. Well, what they did was they made a couple of alterations out here on this side chain, and now they've got this ability to send some stuff over here and knock these guys out, right? It deflects all these guys, kills them all, and makes them so that they cannot do anything to the penicillin. And now this beta lactam ring stays intact and it's able to attack the bacteria, right? So now Staphylococcus is no longer resistant because this here guy has this ability. And they named this, right? It's no longer just penicillin. Plain old penicillin wasn't working. So now they named this guy with this ability to deactivate the penicillinase. That's what these boulders are, is penicillinase. So now we can deactivate it. So this guy here is called methicillin, right? So it's called methicillin. So it's called methicillin. So methicillin can kill Staph aureus, right? Regular penicillin couldn't, but because it's able to deactivate the penicillinase, which is being released by regular penicillin, methicillin is able to kill the Staph aureus, right? Because the penicillinase can't get to it now. And there were several different kinds of this methicillin. One of the brand names was staphycillin. Staphycillin, right? Great name for a medicine that kills staph. And people remember it's a penicillin. And that's what they do with brand names. They want these brand names to be simple. They want them to be easy to remember. And they want them to just tell the doc exactly what this is, right? He can remember really easy. It's unlike the generic names, which are kind of long and hard to remember. It's kind of like Tylenol and acetaminophen, which is easier to remember. Well, Tylenol is a lot easier to remember than acetaminophen, right? Once methicillin was made, there are several variations of these methicillin-like medications that they made, right? So they made several penicillinase-resistant penicillins after methicillin, but methicillin was the first, and it proved to be very effective. But they ended up, improving on making a little longer acting, making it work on other things too. So they ended up with a couple of parenteral types of these. Nafcillin was one, and oxacillin was another one that they made, and those had to be given IM or IV. As far as PO goes, they made some of them too. Some of these penicillinase-resistant penicillins are for PO medication. For PO medications are cloxacillin, Cloxacillin, and dicloxacillin, Dicloxacillin. So that was a couple of those methicillin medicines. So yeah, we defeated penicillin-resistant Staph aureus bacteria, right? Unfortunately, this isn't the end of the story. It worked for a lot of years back in the 1950s or 60s, whenever it was they came up with methicillin. It worked all the way up till right around the turn of the century. Then we noticed that these methicillin-like meds were not working against some of our hospital-acquired Staph aureus infections. So along came the new superbugs, right? And these are called methicillin-resistant Staph aureus, MRSA, right? We call them MRSA for short. That's what everybody still calls it, MRSA. Most Staph aureuses are not MRSA, but some are. And like I said, we call that a superbug. So what are we going to do for that, right? Methicillin isn't going to work. All these other medicines that we made, they're not working against it. Luckily, we came up with vancomycin. Vanco works against MRSA, so it would kill these off. But then, unfortunately, Staph aureus, we got a version of that. It's called VRSA, VRSA, vancomycin-resistant Staph aureus. So now what are we going to do about that? Well, we don't have a single antibiotic that will work against vancomycin-resistant Staph aureus, at least not that will work against it all the time, not just one single antibiotic. But there are groups and combinations that will work against it. So we get a culture and sensitivity, figure out what medicines it's sensitive to, and we'll use them. One of the medicines is called daptomycin, D-A-P-T-O-M-Y-C-I-N. It has limited use because one reason, cross resistance, become resistant to that, and another one is you can get some serious neurological side effects. So how much you can use that is really, it's limited. You can use it, but not a whole lot. Another one is linezolid, L-I-N-E-Z-O-L-I-D. Yeah, it's a bacteriostatic antibiotic, so that means it doesn't actually kill it, but it stops it from reproducing. It stops it from growing and reproducing. Well, you stop bacteria from growing and reproducing, in the long run, you end up doing the same thing as a bactericidal, really. I mean, you kill it off, right? That's the goal. So, in addition to the daptomycin and the linezolid, we have ceftaroline, C-E-F-T-A-R-O-L-I-N-E, and that is a cephalosporin, which we'll be talking about a little bit because most of these superbugs are sensitive to cephalosporins, especially these third and fourth generation cephalosporins, which we'll be talking about. One theory is to prevent vancomycin-resistant Staph aureus, so to prevent VRSA, is to treat MRSA properly. To say treat MRSA with vancomycin and ceftaroline. And when you kill the two of them, it doesn't usually evolve into a vancomycin-resistant medicine. Anyway, Staphylococcus aureus is a great example of bacterial mutation that creates superbugs that continually dodge our antibiotics. I believe this is going to be an ongoing story forever and ever and ever. What do you think? Now, another beta-lactam penicillin-like medicine that we need to talk about is amoxicillin. Most people have heard of amoxicillin because they use it for a lot of things, right? It has been altered to make it more long-acting. And by making it this really long-acting medicine, it's really increasing its spectrum too, so it become a broader spectrum antibiotic. It can kill both gram-positive and gram-negative bacteria. Its problem is that it's really sensitive to staphylococcus penicillinase that kills, so it can kill off the amoxicillin. So even though it's good at killing gram-positive bacteria, it can't kill 90% of those Staph aureus, because 90% of Staph aureus have this penicillinase and they are resistant to penicillin. But to take care of this problem, they've added clavulanic acid, C-L-A-V-U-L-A-N-I-C, acid. They add that to the amoxicillin. When you put those two things together, it'll work because clavulanic acid is a penicillinase inhibitor. So when you put clavulanic acid in with the amoxicillin, the clavulanic acid inhibits the penicillinase being released by the Staph aureus, and in that way, by inhibiting the penicillinase, it makes it so that the amoxicillin is not susceptible to being killed off, I guess, by penicillinase. So now with the clavulanic acid, those two things together can treat Staph aureus. And the name for clavulanic acid, the original brand name for this medicine, amoxicillin slash clavulanic acid, was Augmentin. So a lot of people have heard of Augmentin. You don't see Augmentin on the bottle so much anymore because its patent has run out, and now you get the generic where it just says amoxicillin slash clavulanic acid. But by mixing the two of them together, you got to augment and it kill a lot of stuff. So they use it a lot. They haven't done a culture and sensitivity. They feel pretty safe about using clavulanic acid because it kills so many different things, including Staph aureus. So far, the beta-lactams that we've been talking about are all penicillins, right? They have a molecular ring that looks like the house, right? So they're all penicillins. So if a person is allergic to one of them, they're allergic to all of them. Now, we do have some beta-lactams that are not penicillins. They come from a different mold, right? That's kind of a pun. They come from a different mold, literally a mold, right? Penicillin comes from mold, so does cephalosporins, but it's a different mold. But they're very, very similar in their molecular structure. So when you take a look at them, they do not have the house like here, where the penicillin is. Right? And this is your beta-lactam ring here. Right here, you got your beta-lactam ring. It's not shaped like a house, right? This part is. If you just look at the top part, it's shaped like a house, but the bottom is not that flat floor area. It's shaped down like this too, right? So because of that shape, because it's just a little bit different, it's still a beta-lactam. It still has the attached garage and the little canopy thing there, right? But it does not have the house. And this here knock down the house, well, there's no house to knock down here. It can batter away at this wall, and it will not, it is structurally sound. That's a superior formation that you have in this cephalosporin. So Staph aureus is not resistant to cephalosporins. Now there is some cross-reactivity, right? If you're allergic to penicillin, even though a cephalosporin is a beta-lactam that is not a penicillin, about 10 to 15% of the people allergic to penicillin will also be allergic to cephalosporins. Now, cephalosporins are so good at killing things that they like to give them anyway. So if a person's allergic to penicillin, they will use a cephalosporin as an alternative, unless maybe that person had a really severe, like anaphylactic shock or something, then they might kind of stay away from it. That 15% chance is a little bit too high. But if it wasn't, they will go ahead and try it, and they'll try it in a low dose, and they'll see if this person can tolerate the cephalosporin, because boy, I'll tell you, cephalosporins are good antibiotics, and you do not want to label them as allergic to all cephalosporins if they're not. And in the lab, they've done the same thing with cephalosporins that they did with penicillins, right? They're both beta-lactams. Cephalosporin doesn't have the house. It has that other shaped thing, but then it has the attached garage, and it has the little side chain there that I call the canopy, right? And so they do the same thing. They work on that side chain, and they alter it, and they've been able to do this pretty much the same things that they were doing to the penicillins, they're doing to the cephalosporins, and they're getting these same variations of cephalosporins. But they don't all have all these millions of different names. They actually put them in generations. They have the first generations, second generation, third generation, fourth generation. An example of a first generation would be cephalexin, right? Or Keflex was the brand name. Great antibiotic, works against a lot of things. A second generation cephalosporin is cefuroxime. Cefuroxime. A third generation is ceftriaxone. That's used a lot. Ceftriaxone is used a lot. It works really good on STDs. It works, they will use it a lot of times for when a person's going to have a surgery, before the surgery for prevention, or after the surgery for prevention, whatever. But ceftriaxone is a third generation. And a fourth generation is cefepime, Cefepime. And ceftriaxone is spelled Ceftriaxone. By the time you get up past that third generation, man, they kill a lot of stuff. They're very, very effective antibiotics. And cephalosporins work on a lot of different things. They work on gram-positive, gram-negative bacteria, and including Staph aureus, because remember, the Staph aureus penicillinase doesn't affect them. So they're a pretty sturdy antibiotic, and they work against a lot of stuff. And the labs have done the same thing to these beta-lactam, or to these cephalosporin beta-lactams. Remember, they're made the same way, except they got that little different shape instead of the house. They got that like um, other shape, and then they got on the side there, they got the attached garage and the canopy. So they can do the same thing, but just with that little side chain, they can go making all these alterations and getting all of these same effects. So, and with cephalosporins, what they call them is the original one there, with just a plain old side chain, is first generation, and then they tweaked it a little bit in their second generation, and then their third generation. Now another antibiotic family of antibiotics I want to talk about is macrolides, and this is, they also just call these the erythromycins, because erythromycin was the first one. And you can recognize these guys because they end in thromycin, not just mycin, but thromycin, Thromycin. When they end in that, it's a macrolide. So erythromycin is the big one. You also have azithromycin and clarithromycin, right? Let's take a look at them. Right, so you might have erythromycin, azithromycin, and clarithromycin. Right, so those are the three macrolides that you see out there. And these guys are at least bacteriostatic. Some instances they're bactericidal, depending on what you're using them on. But they're bacteriostatic against Staph aureus, and they are not a beta-lactam penicillin, so they're not affected by penicillinase. So that's a nice advantage, right? You don't have to worry about trying to tweak them to make them so that they can resist penicillinase, because they don't call it erythromycinase, right? They call it penicillinase for a reason, right? It's not affecting the erythromycin. But their action is to block microbial protein synthesis. If a bacteria cannot synthesize the proteins, it cannot grow or multiply, right? So that's bacteriostatic, but like I said, might as well be bactericidal, because the end result is going to be the same thing. And these guys are really broad spectrum. They kill just about everything, right? And like everything that's broad spectrum, when it's broad spectrum, you got to worry about secondary infections, right? You kill off the friendly bacteria as well as the pathogens. But these erythromycins, right, they are a drug of choice for gonorrhea, right, which is an STD. They're good for respiratory infections. They'll kill Helicobacter pylori, which is a infection in the stomach, right? Bacteria that can live in the stomach. Erythromycin is one of the antibiotics that can kill that. Now, azithromycin is long-acting. And that's nice. It enhances compliance, right? In other words, what I'm saying by compliance is the cooperation of the patient to actually take the medicine the way it's prescribed to take. This is so long acting that most patients go ahead and they comply, because it's not so easy to screw it up like it is these other more difficult regimens where you got to take it 2 times a day, twice a day, whatever, for 2 weeks and stuff like that. You'll take sometimes you'll take 500 milligrams the first day, and then the following 4 days you take 250 milligrams. That's it. 5 days. Right, they give you that 500 usually before you leave the office. They give you a prescription. You go home. You take one 250 milligram tablet a day for the next 4 days. So you got to remember 4 times, right? You got to remember 4 times to take 1 pill every day, and then it stays in your system and keeps working for like 2 weeks or something like that. So great medicine. And sometimes, it depends on what infection you have, but sometimes they'll just have you take 500 milligrams a day for 3 days, right? For gonorrhea, we actually give them 2 grams, all right, a one-time dose, 2 grams. You give it to them right there in the office. they leave, you don't have to worry about them being compliant, because gonorrhea is an STD, and you really worry about compliance because you don't want them out there spreading it anymore. So you give them that 2 grams, boom, they're out the door. You don't have to worry about them compliance. Of course, you do want them to be compliant in the instructions you gave them to be abstinent, right? You tell them no sex, right, for 2 weeks or until this thing is cleared, and that's what it is. It's not, use a condom or do this or that. It's no sex for 2 weeks, right? And some people just won't comply with that. Tetracycline, we're talking about another bacteriostatic medicine now, right? We're talking about the erythromycins. Now I'm talking about tetracycline. And how was it named? Remember when I talked about tetralogy of Fallot, and then it was an extra point I put on there for how many deformities are there in tetralogy of Fallot? And I couldn't believe I'd say more than half of the class missed that, and that should have been an easy extra point because tetra means 4. You ever played Tetris? It's a game that you used to have to take, and there's 4 little blocks, and you got to kind of move them around to get them to fall down, and they land in there without leaving a space. And that's why they name it Tetris, because it's a combination of 4 blocks. And that's what tetra means. And that's where tetracycline gets its name, right? It's got 4 of these. I think they're just like this, rings. And I don't know what they got up here, probably some carbons and some nitrogens and stuff, but it doesn't matter. But anyway, they end up with these 4 rings, and that's where it gets its name, right, from these 4 rings. And so you got tetracycline and doxycycline. That are the 2 big medicines in this family. And like erythromycins, tetracyclines also block protein synthesis, and they're broad spectrum. They're used for chlamydia, and it's the most effective antibiotic we have against Corynebacterium acnes. And let me show you that. And they kill Corynebacterium that's a CT, bacterium acnes. Acnes, that there will give you what we're talking about, AC, acne, right? So tetracycline is the most effective antibiotic we have against this particular bacteria that causes acne. So let's see, and on tetracycline, the antibiotic tends to bind to calcium. For this reason, it's not used in rapid child growth years. So you got a child in the rapid growing years, they don't use it at all in them. It's not used in pregnant mothers. Pregnant mothers, it can set in the forming teeth of the fetus, and it will cause permanent gray staining in the person, so they'll live the rest of their life with this staining. Now, you got to remember, adult teeth form in utero, right? At about 4 months of pregnancy, the adult teeth are formed. Now, they don't break through, right, until the kid is like 5 or 6 years old, right, because they get their baby teeth first, and then the adult teeth finally come through. But they do form, and that's unfortunate, because that's why during that period, if they were taking tetracycline, they will have these gray stained teeth. Okay, so now I'm going to talk about aminoglycosides. Aminoglycosides, gentamicin is the big one on that. These antibiotics also inhibit protein synthesis. They're effective against gram-negative bacteria. They're often used for meningitis or septicemia. The peak and trough levels need to be drawn on patients that are taking this medicine, right? Because you don't want them to drop down in the subtherapeutic range, and you don't want them to get up in the toxic range. Toxic levels produce problems with the ear, so they're ototoxic and they're nephrotoxic. So problems with the ears, you're going to be watching for signs and symptoms. This could be manifested by dizziness, right? Because the ears are important for your balance. Tinnitus, that's a ringing in the ear, or progressive hearing loss. Those are all what could be signs of ototoxicity. And then they're nephrotoxic. Nephrotoxicity, you watch your BUN and creatinine. And remember that gentamicin is physically incompatible with heparin, so you don't want to put it in the same IV line as heparin. They'll crystallize. So now let's talk about quinolones and fluoroquinolones, right? And this is ciprofloxacin and levofloxacin. All right, so ciprofloxacin and levofloxacin, they affect DNA. What they destroy DNA. They actually affect topoisomerase. I'll show you that. topoisomerase. Topoisomerase. Right, so they affect topoisomerase. Well, it ends in ace, so that we know that it might be pronounced topoisomerase, but I don't think so. But anyway, so it ends in ace. We know it's an enzyme. That means it's going to be like breaking something up. And what's it breaking up? Well, you look to the front of the word. It doesn't really tell you much. Topoiso. So, but I can tell you what it does, right? Topoisomerase, what it does is, remember, you know how DNA, whenever you see it drawn, they draw it, it's curled, right? It's like you took a ribbon and you twisted it, right? Well, as it's cranking itself out there and it's forming itself, it can get really hyper twisted, I guess is how you could call it. It gets way over twisted. It gets twisted too tight. Topoisomerase is a really neat enzyme that what it does is it comes in there. It's like it's got two ends. At one end, it's got a cutter. What end do I want it to be the cutter? One end is a cutter. The other end is something that puts things together. So what it does is you got this thing coming out and it's getting twisted too tight. And so it comes up and it cuts it. And then it unravels. And then the other end of this topoisomerase grabs it and puts it together. Right? Cuts it, puts it together. Then it sits around and waits. Oh, it's getting too tight again. Cuts it, unravels, puts it back together, right? That's what topoisomerase does. Ciprofloxacin and levofloxacin, these quinolones and fluoroquinolones, really neat what they do. They affect topoisomerase. They make the cutting end work faster, and they impede the end that puts it together. So this end is just cutting that DNA all up, and this end's not putting it back together. So you end up with fragmented DNA. So this is bactericidal. You got to have DNA. You can't make all of the things it takes to live without your DNA being put together, right? And when it's all fragmented, it kills it. So it can't reproduce, let alone even survive. So now we're messing around with DNA, right? You don't want side effects on this, and it messes around way more on the bacterial, but it can screw up our own. So you do not give this to children. Right? You don't give it to anybody who is growing fast, right? You don't want to give it to them. So, and in fact, anybody less than 18 years old is not recommended for getting these antibiotics. And so mess around with the DNA, we can imagine the teratogenic effects, right? Now it's been well documented and studied on animals and bad teratogenic effects. However, on humans, we don't have the studies because we're not going to give a pregnant woman this antibiotic just to see what happens, because we know what's going to happen, right? So we really don't need the human studies. So it's as bad as it gets, right? So even though we don't have the human studies have shown part of it, we don't need that because we know what human studies would show if we did it. Right? We would have bad deformities. Another thing, we don't give these medicines to people who are on corticosteroids. They don't mix. Elderly people with musculoskeletal disorders, you don't give them to them because increases the symptoms, right? They have a really bad disorder and they take this here and it just makes it a lot worse. So you don't give it to them either. And cardiac dysrhythmias, don't give it to anybody with cardiac dysrhythmias because it can make them worse, especially if you have QT prolongation. This here can lengthen that to the point where the person ends up in asystole. So that's what it's not used for, right? It's not gonna. That's another thing it's not used for, I should say, is people with cardiac dysrhythmias. Okay, so I think that's all I'm going to talk about. I think I've talked about pretty much everything that you're going to need. So go ahead and watch this, and hopefully you can pull out the things that are important. There's a lot in here that I can't test you on. There's a lot that I had to talk to you about just so that you kind of understand what these medicines do. Hopefully this is less confusing than the PowerPoints were, but between the two of them, in fact, I'd say